Hello, everybody, and welcome to the Bad EM podcast. My name is Daniel Still, and I'm your host. Bad EM stands for Brave African Discussions in Emergency Medicine, and this is a platform we use to try and find African solutions for African problems. This is episode 3 of season 3, and today we are talking about community pediatrics with Dr. Dave le Roux, who is the district pediatrician for the Metro West subdistrict of the Western Cape, while working clinically at Mitchell's Plain Hospital. We talk about community health and how complex health ecosystems need complex solutions to attack the problems they face. We talk about data that relates to community health and who should be tracking it. And then we get a bit more granular with regard to referral pathways and relationships between emergency medicine and peds, notably with regard to investigations and workups. Without further ado, welcome to the show, Dave. Would you mind starting us off by introducing yourself and giving us a brief background of your professional career so far?
Yeah, so my name's Dave le Roux. I'm a district pediatrician for Metro West here in Cape Town. I studied at UCT, did my internship at Baragwanath in Joburg, did my community service outside Limpopo. I worked on the platinum mine, came back to Cape Town. I did a diploma in obstetrics. Then I went to work at Red Cross, and I've been in peds ever since. I was lucky when I, in 2007, got a fellowship to go and study public health in America. So I was able to do a master's in public health in Baltimore, which was absolutely amazing, completely changed my life. And I suddenly started to understand how I felt about upstream determinants of disease and the population impact of child health. So that was really very, very nice. Came back and finished my registrar time at Red Cross. And then worked at Somerset for a bit, and I've now been at Mitchell's Plain for 4 years, and really enjoying getting into the community pediatrics side.
Nice. And then for those of us who aren't familiar or other specialities who don't have a similar role, how does a district pediatrician fit into a health system?
It's quite interesting. In America, a district pediatrician or a community pediatrician, it's a public health pediatrician, where they're looking at integrating public health concepts within children and family. In the UK, a community pediatrician is a developmental pediatrician. So they deal with autism and ADHD and school health. And there are loads of jobs for community peds in the UK if you've got a developmental background. But it's not a common specialty in the UK as a public health pediatrician. So we recently got the ComPeds recognized as a fellowship, as a subspecialty through the Health Professions Council. And we've actually been pushing much more towards the American vision of community pediatrics being pediatric public health. So we do look at development, we do look at autism, ADHD and school health, but we're much more looking at the social determinants of health, child health and community linkages. And it's much more for public health than it is development. Yeah. And that's the way we're trying to build up this fellowship in community pediatrics.
And then the diploma in community pediatrics.
Yeah. So we've been running a postgrad diploma for 10 years through UCT in community and general pediatrics. And then last year we kicked off our MPhil, our master's subspecialty for pediatricians who want to subspecialize. So we finished our first year last year, but our inaugural pair of candidates who are both Victoria Hospital pediatricians who are doing their MPhil subspecialty, and we're evolving the program. We're building it as we run. Yeah, and we will finish up this year, and we'll graduate our first 2 locally qualified community pediatricians at the end of this year.
Awesome! Congratulations! I think it's a much needed gap that you guys are filling slowly.
Yeah, hey, we're very, very fortunate to have such great candidates, caliber candidates for our first 2 who've really been able to help us as we fumble along with this building the syllabus and the curriculum. They've been able to, actually that wasn't a great assignment. And that thing that didn't work so well. Yeah. Rather try it this way. So Ben and Tandy really contributed to building the syllabus and the system as we've gone.
Yeah. That's also quite nice engagement as you do something to mold it.
Yeah. Yeah. And to get live feedback on your assignments and your exams.
And then moving sort of in the same direction, in terms of complexity, you made a LinkedIn post recently about the difference between complexity and something being complicated, and how health systems, especially pediatric health systems, are very, very complex, from a community-orientated sort of drivers of healthcare to referral pathways to the difference between urban and rural levels of training and the patient-orientated and the doctor-orientated setup that we've got going in most of South Africa. Would you touch more on that and just explain how you see that?
So I was listening to an Adam Grant podcast in between the Bad EM podcast, and his guest was saying that something complicated, if it's got multiple different steps which need precision and engineering and very fine tuning, but you follow them in the steps, follow the recipe, and you're going to get the same outcome. He said the example he used was getting a Ferrari. If you follow the same steps, you're going to get a Ferrari. You're not going to get a platypus.
Yeah.
As opposed to a system which is complex, where it's not a repeatable recipe.
Yeah.
Where you do the same thing and you get a different outcome. Where you push here and something gives and something changes, and you can't implement the same thing in a different context because it doesn't work.
Yeah.
And the example that he gave on that podcast was raising a teenager. You can't raise every child the same using the same incentives and discipline and structures. You constantly having to change, you outgrow one method, you move into something else, and it's very iterative. It's hyper unique, and it's something that you need to grow and learn into. You can't just transplant a model from a different context. And that was maybe think about health systems where visiting different clinics, where one triage system works well, the same system in a different context won't work because of the infrastructure or the staff or the geography or the patient flow. It needs to be adapted. It needs to be changed. And you can't just cut and paste solutions. You can't cut and paste best evidence, I'm doing air quotes here, from one context, one health system into a different health system. Everything has to be trialed, adapted, implemented, iterated, and there has to be that constant improvement cycle.
Yeah.
Try to find the best local adaptation and it drives me crazy in child health in Cape Town. These key registrars, they work at Red Cross, and then they rotate to Somerset, and they say, we should do this. And I'm like, no, you shouldn't. That's a terrible idea. That works at Red Cross ICU, but it's not going to work at Somerset. Different patient population, different nursing staff, different burden of disease. Whatever you do, don't bring your Red Cross best practice into a completely different, and the worst thing is when you used to do outreach up to Vredenburg. Now they want to take the Red Cross ICU protocol and then implement that in Vredenburg. It's terrible.
And that's using hyper-local situations. The difference from Red Cross to Somerset is not a very big jump.
But it's 12 kilometers.
Exactly. But Red Cross to Royal Eastern Cape is a huge jump, and applying and getting a system improvement project that is beneficial for broad level pediatrics is a nightmare.
Yeah. So we want people who are passionate about best evidence, but are equally interested in local adaptation.
Yeah.
So, and without those two held in balance, you can't have the one without the other.
Yeah.
You have to be interested in evidence. You can't just be locally adapting your own ideas.
Yeah.
You've got to have the evidence, but you've got to be committed to local iteration and adapting and fine tuning. And there's the complexity. Like nothing is going to work perfectly in every situation. Everything has to be adapted. In my subdistrict. Yeah. So we drain in Mitchell's Plain subdistrict. There is the southern bit, which is the suburbs of Mitchell's Plain, and then the north, western from the hospital. That's Philippi, Brown's Farm, Samora Michelle, into Vivaletu. Two totally different communities.
Yeah.
Different access to health, different expectations, very similar diseases. Yeah. But the lived reality is quite different in those two contexts.
And the cultural demographic.
Very much.
Very different, yeah.
So you can't just copy and paste the solution that works at one clinic into a different clinic. Everything has to be adapted and taught and tried, and it's hard work. It's slow going.
And is there a space or a plausible way to get more exposure? Obviously, your community pediatricians are one way to do this, but they've chosen to do this. Is there a capacity to get your normal registrar, your normal medical officer, more community exposed? For example, rotating through clinics, seeing both sides of the service delivery pathway, etc. Because a lot of the, from personal experience and not necessarily with peds, but working in different settings along the same referral pathway often garnishes a lot of understanding and empathy and experiential wisdom, so to speak.
Absolutely. I think it's absolutely essential that you as a trainee, that you're exposed to and work at different levels of care. It's all very well if you're a single organ specialist and you only work at tertiary. That's fine.
Yeah.
If that's all you work in, then that you can be very good at that.
And
you never need to leave the building.
Yeah.
That's absolutely fine.
And your services wouldn't be useful other places either.
And you mustn't be the one to draw up the guideline for implementation of the provincial policy.
Yes. Yeah.
Because your expertise is within one facility. Somerset Hospital is great. They do a wonderful outreach program where the registrars and MOs who rotate through Somerset, they go up to Bredinburg and they go to Westfleet and Atlantis. So they actually go and walk through the labor ward.
Yeah.
When a sick baby is born, the midwife will phone from Westfleet Hospital, and then you can say, okay, so you're standing there in the labor ward, and I was there last week. Now on your left, there's this piece of equipment, and on your right, there's this, and there's now the other side of the recess, and you've actually been there, and you can talk them through a recess because you've actually physically been in the labor ward where they're.
Yes, yeah.
And you've got so much more insight into what's available. And you won't say, do this, run this infusion, repeat the blood gas, and call me after 6 hours.
Yeah.
You're much likely to say, send. I know what you're dealing with. Let's get them across to a different level of care.
Do you think this approach, speaking from your personal experience as a district pediatrician, do you think that this community approach should and could be adopted by other specialities in terms of, like you said, a single organ specialist in a tertiary hospital, not necessarily, but in terms of emergency medicine, surgery, things like that, a broader approach to issues of our subdistrict, and to, like you said, not necessarily to create policy, but also if there is more of an understanding, then there would be more capacity to do that.
Yeah, I think that's essential. Part of health information and that being a data informed health system. It's not important that everybody has got access to the data.
Yeah.
But somebody has to. Somebody needs to be looking at the data and knowing where the burden of disease is shifting.
Yeah.
And I do that for Metro West. I do an annual child mortality head count.
Yeah.
For Metro West, integrating in hospital deaths, in wards, pediatric wards, and their front room and DOAs from Hectus, and then forensic pathology, all of the out of hospital deaths. And last year we worked out that 17% of under 5-child deaths occurred in a pediatric ward, and about 40% occurred at home or outside a facility. About 40% were in EC.
Okay.
But a very small minority were actually in the pediatric ward. Most of them were well before getting to a peds ward. And it's not important that everybody knows that. Everybody needs to work in their space and be an expert at their level in their context. Somebody needs to be looking at that.
Yes, yeah.
I'm just preparing the data for I'm presenting this at Red Cross again next week, and looking at Mitchell's Plain Hospital. EC deaths almost double, went up by 50% in 2025 compared to the previous year. The natural deaths were about the same. It was 11 in 2024 and 13 in last year. But the non-natural deaths have doubled. In one facility, the non-natural deaths literally doubled from year to year. And I didn't know that until I looked at and you add it up month by month, and suddenly it's a 100% increase from year to year.
And you wouldn't have necessarily just noticed that anecdotally.
Well, you wouldn't, because you're not on every shift.
Yeah.
And sometimes you're on and you're off and you hand over, and it was a bad week and we had another PVA or gunshot. But only when you look at the stats do you realize something's changed.
Yeah.
So because we work in an ecosystem, you can't look at one facility.
Yeah.
You need to now look at the whole system and what's happened at the CHC and at Crossroads and Google Leeds and Red Cross. Is this just a local blip, or has something actually shifted? But that was striking when I saw that yesterday. I was like, oh my goodness, what's happened? And that doesn't change what you do in the front room.
Yeah.
If you need to know your ABCs and your resuscitation protocols and your adequate safety netting on discharge, that doesn't change. But somebody needs to be looking at the burden of disease and geomapping these. And as I mentioned earlier, McSpain Hospital draws from two quite distinct populations. And I need to look at where did these kids come from? What happened? Was it a universal increase in non-natural deaths? Or is there actually something in the data signal to say, here's a hotspot, we need to direct resources towards a specific hotspot?
And then speaking of stats, and with Child Public Health, a circular that you sent out last year, which I think was also promoting your diploma in community child health, to quote a few of the things in your email, you said that antenatal coverage, so booked pregnancies, has decreased for the 4th straight year. Neonatal deaths are up. Under 5 child deaths are up. Low birth rate proportion is up. Exclusive breastfeeding at 14 weeks is down. And then TB treatment initiation in children is down. And then the measles vaccine coverage, which improved since COVID, but is still stuck at 85%, which is well below the herd immunity threshold. With drawing on from a lot of the themes you've touched on already, how do we combat that? What's the answer to taking broad systemic issues like that, and from a public health and a clinical perspective, turning the corner with those?
Yeah, that's really interesting. I think it's quite interesting as South Africa goes through a demographic transition. We have moved beyond the emerging lower income economy, the very broad-based population pyramid. We are having actually fewer births each year, and our pyramid is looking to look more like Switzerland, less like Nigeria. So we're becoming a vertical, flat-sided pyramid.
Yeah, more steep sides.
More steep sides, yeah.
Yeah.
Which means that women of reproductive age are accessing contraception, and there are fewer. There are more planned pregnancies, fewer unplanned pregnancies.
Okay, that's good.
So all of the lower risk people are accessing contraception, not having babies, and many of the babies are relatively, well, there are few babies, but a high proportion of the births are high risk. They're contraception failures, or there are people who didn't access care. And so as you take all of the low risk people out of the population, what's left is a high proportion of high risk.
Yes. Yeah.
ARV defaulters, unbooked pregnancies. As you take out all of the adherent people who prioritize health seeking behavior, they're not having as many babies. What's left is the hard to access populations.
Yeah.
So we get a high proportion of unbooked ARV defaulters than we used to, because people who are not defaulting ARVs are also taking contraception.
Exactly. And then they're having less babies.
And so what's happening is our birth rate is decreasing, but the proportion of high risk pregnancies is increasing.
Yeah.
So we're having a high rate of vertical transmission. We're having a high rate of complications, massive increase in syphilis. So that's one thing. It's a higher risk population, fewer births, but more complexity within that. And then in terms of interventions, there's no more low-hanging fruits in pediatrics, maybe even in the whole health system. Possibly GLP-1 antagonists might be a low-hanging in adult medicine.
Yeah.
But there's not a single molecule that's going to save us. You know, we had high hopes for nevirapine and stuff, but at the moment, all the interventions are complex, system-related, access to care. It's all very well having vaccinations, but if people don't want to come to facilities to receive the vaccinations, then it's not effective and it's not helpful.
Yeah.
And so the interventions are around access to care. We need to design systems which are more accessible, more appealing, less punitive, and the solutions are upstream of the emergency center. The ECD is picking up the problems of the system failures, but the power to enact change and actually make a significant change is outside of the EC. That's upstream at the level of
community development.
community developing, getting pregnant women an ID document so that they can register the birth of the baby, to get an ID, a birth certificate, so they can access the child support.
Yeah.
Now, that's not the role of the emergency center to get the mom an ID book.
Yeah.
But the baby's not going to get a child support grant until the mom's got an ID book, and somebody has to do that. And it's not fair that the burden of this falls on the EC because of this tsunami of unwellness.
Yes. Yeah. They've got a few things to do already.
Yeah.
Yeah.
Absolutely. Yeah.
Yeah. So it's complex answers for complex problems, essentially.
And a lot of them are upstream. They're not held within the health system.
And that also speaks to the need for linkages with the Department of Social Development and infrastructure planners and the mayor's office and things like that. And NGOs, of course, because sure, Cape Town, or the Western Cape especially, is riddled with NGOs trying to do the right thing, but it's all about collaboration and needs-based work.
Yes. Yeah.
Yeah.
So I want to look into this surge in non-natural deaths in Mitchell's Plain and look at them case by case. And are they, is it gunshots? Is it road traffic accidents? Is it organophosphates? Like, what is the thing that caused this increase?
Yeah.
And we need to know, we need to geomap them. And there needs to be a targeted intervention. We can't just wring our hands and say, shucks, this is bad. We need to know. Well, we need to look at the data before we hypothesize about what are the causes.
What we need to do, yeah. And then on a more micro level of referral pathways, and this also is out of hospital, but in most of the emergency units I've worked in, the pediatric department and the emergency unit have very different arrangements in terms of who sees who. And I think this is also the case nationally to an extent, but I can't say for sure, where the emergency unit sort of sees some pediatric patients but not others, and then some pediatric departments are on site and help out with them and then refer onwards, but some go straight to tertiary level. And it always seems to create a bit of a mismatch of responsibility and often a bit of animosity between who's responsible for a sick child at the hospital when there's an emergency department and a pediatric department upstairs, and then the child might bypass the pediatric department and go straight to Red Cross. So as the district pediatrician, or as somebody with public health experience as well as a clinical background, and you said earlier, different policies and protocols don't apply to different units. But should there be more broader policy when it comes to that, or should we stick to whatever works at a specific hospital?
Yeah, that's really interesting. And it's a system that's very much in flux. I came out of the old district health system, which was very much hierarchical, district by district, replicating within each district and then escalating beyond that. And so in Cape Town, you'd have to then have the primary level, the level 2 facility, and then escalating to the tertiary center, replicated at each district and sub-district. The new ecosystem model, where you take a whole geographical service area as an entire ecosystem, and it's not negating the municipal districts.
Yeah.
But we're saying we don't have to replicate every single service within every single district. We can have some services which are transversal across the health ecosystem. And that's the example that they gave was of some radiology and ophthalmology posts, where that post can be held centrally at the tertiary hospital. That person will then provide a service at 4 different facilities. So each hospital doesn't have to employ their own urologist.
Yeah.
They can have access to the pool, the centrally held pool. And 1 day a week, there can be a urology service.
Yeah.
But they don't have to employ their own urologist. And similarly, ophthalmology, radiology, most reporting can be done centrally. You don't have to have somebody there on site at every facility. Interventional stuff is different. And that can be a bit of a game changer for efficiency.
Yes.
And also managing to move patients across the system, where we're not completely bogged down about where did the patient start their health journey, which facility they started in, what is their home address.
Yeah, exactly. Yeah.
If they're within the ecosystem, then they need to access the appropriate level of care, but they can actually move through that
quite easily.
Fluidly. Yeah.
Yeah.
So that's being worked out. We've got a meeting coming up where we're trying to thresh this out at a pediatric level. And what do we do with our level 1, 2, and 3 beds in general pediatrics and neonatology? And where do we need, does it matter where the beds are held?
Yeah.
If they're available to everybody, we can have more beds at Mowbray than at Metro Slate, as long as they're seen as a shared resource.
And not our beds and your beds.
Yes.
Yeah.
So take it back to that EC question. If there is local expertise, then that's great. If not, then the patient must move to meet the expertise. But that a lot of the time depends on relationships and trust.
Yeah.
It's very difficult to walk in as an outsider, read the local unit policy, and then action that if you don't know the person that you're dealing with.
Yeah.
Whereas if you're in the system and you've used the pathways before, then there is that relationship and there is trust. And you can say, hi, I'm phoning from this facility. And they're like, oh, that's fine.
Yes.
Fine.
That's one of our facilities.
You guys want to send these patients to us. No questions asked, book the transport. But that's got to be, that is got to be
pre-established.
Yeah.
Well, that trust comes over time.
Yes.
But that relationship needs to be both formal and then informal in the way that trust is gained.
Yeah.
Yeah.
And we can't have there's a fair amount of animosity between, a lot of the adult disciplines, where there's this refusal to take our patients. Colleagues talk about trying to refer adults to, within certain subspecialties, to Grootskeer. And the subspecialty says, no, we can't. We're not protecting the referral.
No.
What am I supposed to do now? And that's very bad for relationships.
Yeah.
Bad for trust.
Yeah, big time. And then in terms of the patient moving to the expertise, could you touch on readiness and how we need to make different units and different levels build the capacity to an extent and build the readiness of a unit to be able to deal with a pediatric sick patient?
That's difficult because a lot of units, the high burden and the low burden units, have got different experience and different capacity. Once again, just looking at the under 13 deaths, one clinic sees about 100 children per month, and they had one fatality last year. Another facility sees about between 35 and 50 children per month, and they had 12 fatalities. And so the low, and Mitchell's Plain, we see nearly 1,000, I think between 800 and 1,000 children. And so the very high burden units have got expertise and experience. Other units are relatively quiet, but when a child arrives, they're critically ill.
Yeah. And they don't necessarily have the expertise when the sick child arrives. So it's a bit less frequent that when it happens, it's bad.
And it's very scary. And so people don't gain confidence. They don't have lots of experience with the moderately sick children.
Yeah.
They see very few children and then one arrives and it's a disaster. And that's not great. That's not a great way to run a health system where you're only seeing resusces. So I'm just so glad that the clinicians rotate. Look at the names of the treating clinician on HEGS. You can see that these people have got experience across the system.
Yeah.
They were in the right place at the right time.
Yeah.
Very difficult to build that expertise in-house. Unless you're having the volume. So we need to rely on our high volume centers of excellence for training experience, and then deploy those staff wisely throughout the system.
And also make it easier in those infrequent situations for a seamless access to experience.
Yeah. Yes.
So if that's not there at the time, sort of scoop and go, to recognize that is not there very quickly, scoop and go and get them somewhere quick without any systemic barriers to access.
And telephonic support is not very helpful in those situations.
Yeah.
You've got to have hands-on local support.
Yeah.
SIMs are great. The APLS, ACLS where you're doing lots of training on simulation training is excellent for individuals, but it's golden for teams. To do a sim with your own nursing staff in your own unit. Is worth 100 lives. It really, really is. So we should probably be doing more sims. We should build up our simulations
at different units.
And not extracted. So you don't take one person away through extensive.
Yes.
There should be simulation outreach, going to the facility, going to the unit.
With realistic situations that would happen at that unit.
Yeah, half an hour Friday morning. Let's all get the whole team in. We're going to run a sim.
And then, remember, clinical question. PEDS in a lot of settings is synonymous with very extensive workups. In terms of bloods, LPs for a PSBI protocol or neonatology, for example. And that, from an anecdotal perspective, does not always follow the protocols that have been circulated from a provincial or national level. And it almost feels like to be admitted, one needs to have a workup. Whereas I know in a lot of other countries, and personally I feel would be appropriate in some situations, some select situations, an admission for observation without any bloods or anything like that, either because the safety netting is not great or the access to hospital is not good, or just because you think this child potentially could be sick, but you're not clinically worried about them and you just feel a bit uneasy about sending them home, but they don't warrant a workup at this point. And I feel that could be cost saving, but could be beneficial for a lot of people. That's where we often hit the brick wall of EM versus PEDS, and PEDS wanting, okay, well, if you want to admit, then we got to do this, this, and this, and this. So where do you think it's appropriate to compromise in a situation like that? And where do you see a rational path?
I think that's absolutely spot on. And that is definitely a kind of junior versus senior clinician issue.
Yeah.
Whereas juniors don't have the confidence to admit without doing investigations. And I think it's, as you said, the gestalt, the feel of the patient. This is what I'm worried about. This is what I'm not. And you can't teach that.
Yeah.
In terms and cosmos, you need years of sick children, sick patients, recognizing that this one is different. This one is not like that one.
Yeah.
And being able to pull them off the bench and say, this is the one to worry about. Everyone else is fine. And it's very difficult to put that in a protocol. And very often, kids are admitted overnight, and I'm doing the ward round, and the interns want to tell me the blood results. I'm not interested. Yeah. This patient shouldn't have had bloods, shouldn't have been on antibiotics. Don't tell me the results. It's like, this is not appropriate. I
don't want to know if the CRP is 22.
Absolutely. Yeah. And so much better to have a safety net admission for non-medical indications based on the family's access to care. Are they going to be able to return safely?
Yeah.
Another puncture. Just want to know that the child's safe.
Yeah.
Just observe them overnight. No antibiotics. They're better in the morning. They never needed antibiotics. Yeah. Maybe it's a problem on the pediatric wards that the seniors who doing post and check round are demanding these
things. Yeah.
But I feel it's driven more by anxiety amongst the juniors. They don't want to turn up on the ward round with a patient who doesn't have a full battery of bloods. And I think it's different also in different specialties. If you're a general EC, you're admitting for orthopedics and obstetrics and internal medicine. And there's a different threshold for investigating in each of those.
Yes, very much so, yeah.
I almost always feel that the patients will over-investigate. Sometimes it's on protocol, sometimes it's just anxiety. But often we've got asthmatics who are admitted with an IV line.
Keftrax and
exactly. Yeah. And what they need is oral steroids and metadose inhaler bronchodilators. They never needed anything intravenous. They certainly didn't need a blood gas. There's this over-reliance on blood gases, as if that's going to demonstrate that the patient is sick or unwell.
Either okay or not okay, yeah.
And I've now requested, before you do blood gas, send me a video of the respiratory effort. I will tell you if you need to do a blood gas. And if a child is got increased vertical breathing and they've got massive recessions and they're grunting, they're physically tiring, I don't care what the blood gas shows. they're in respiratory failure, they need extra respiratory support. If the CO2 is 2 or 6 or 8, they're not going to cope. They're going to wind up on CPAP sooner or later. Doesn't need a blood gas, needs to go to and get onto CPAP.
Whereas on the other side, you often get sort of asked, what's the blood gas looking like before you've even said your name?
Yes.
Yeah.
Yes. Or they will do an intervention and then repeat the blood gas. But well, how's the patient? No, the patient's fine. He's running around. Well, in that case, blood gas is probably going to be fine.
But like you said, very difficult to put that into policy and very situational in terms of who's on the phone and their level of experience.
Absolutely. And if we're going to be practice defensive medicine, we're always going to wind up over-investigating. It's very difficult to see a way around that.
And then last question, if you had a magic wand and you could wave it and something would materialize overnight in South African pediatric healthcare or African pediatric healthcare, what would that be? Yeah,
it's difficult to, I've got a background in infectious diseases, so it'll be tempting to go for HIV or TB or malaria or vaccine preventable diseases. But I think, just as we were talking earlier, so many of the health problems are not within the health sector. And if I were to have a single wave of the wand, just one wave, I would want to take it outside the health sector and above. And I'd go for something like an end to structural poverty, safe water, safe housing, electricity, sanitation, food security, income, basic income. I think so many of the problems of gangs and drugs and red zones and crime in the Cape Flats, it's structural poverty which is driving that. And the secondary health outcomes, all downstream of that. The problem of sudden infant deaths in Manenberg would be better if we got on top of the poverty and the social drivers of poverty in gang-ridden communities. So that would be it. It would be structural poverty. And then that would not deal with autism. We'd still have childhood obesity. We'd still have lots of behavioral, lots of developmental, lots of nutritional problems. But I think addressing structural poverty would take away probably 50% of the burden of disease of what we're experiencing now. So that would be, if I had one flick of the wand, I'd go with that.
That would be delightful if that could be fixed with one magic wand. Well, yeah, thanks so much for joining, and I really appreciate the time that you've taken and the very insightful answers. So yeah, thanks.
Brilliant. Thank you so much.
And that brings us to the end of the episode. We hope you found today's conversation as insightful as I did. We explored the world of community pediatrics and the reality that intricate health ecosystems demand equally sophisticated approaches to solving their challenges. We dug into the role of data in community health and who bears the responsibility for monitoring it, before zooming in on the practical dynamics between emergency medicine and pediatrics, particularly around referral pathways and the workup of patients. Be sure to rate, review, and subscribe on all of your favorite platforms, and share the podcast with a friend or a colleague who might be interested. If you'd like to get in touch, find me on LinkedIn or email me at dan@badem.co.za. Follow us on Instagram and Facebook at Brave African Discussions and X or Blue Sky as BAD EM. Thanks for listening. See you next time. Bye bye.